One conversation at a time. That's how we fix the nation. And we are thanking you very much for choosing this as a way to fix the nation. Joining us, Eric Latif, Mariam Bishar, and Janet Bogwa. So we can have these conversations on a daily basis. Every day what we are doing is contributing, all of us together. The three of us in the room, plus you joining us on Nation FM or on NTV, or joining our live streams on YouTube or Facebook or Instagram or TikTok or X, and just contributing to fixing the nation. In the next hour, we want to make SHA make sense. No, we do not want to make SHA make sense. We want the chairman of SHA to make it make sense. And that's why he's here. He's Dr. Abdi Mohamed. Before we welcome him, you know what we do at the beginning of every hour? We track what the newsroom is tracking. And what's our news fix, Janet?
According to amnestykenya.org, there is hashtag free all political prisoners in Uganda protest now set for today, actually, Monday 24th, 2025. They've talked about organizations wishing to inform the public that they want to plan a protest because of the continued detention of Dr. Kizza Besigye and others illegally detained in Uganda, and that it has been rescheduled and it's taking place in Nairobi. They do talk a little bit about why there's the change of date. It's according to the Uganda court to give the opportunity to hear and act on the collective voice of Ugandans, East Africans, the Commonwealth, and international community for a fair legal trial, the immediate release of Ugandan political prisoners, and justice and respect for human rights to prevail. So this whole issue of Dr. Kizza Besigye has completely gained momentum, and now they're saying this is the voice of Ugandans, East Africans, the Commonwealth, which is a little bit rare for the Commonwealth to really get involved to the point where they're saying this raises question marks. True. They're usually quite neutral. So that's just an update on that ongoing conversation. So waiting to see, it's supposed to happen from 10 a.m., waiting to see what will come out at the back of those planned protests.
Right. There's also an update as far as this impasse between RUPHA and SHA escalating. According to RUPHA, the government owes hospitals about 30 billion shillings, a debt mostly accrued under NHIF. 22 billion of this is owed to private hospitals, and 6.9 is unaudited claims. There's a little bit of a clip there from our coverage of this RUPHA-SHA, of course, impasse. Jackson, if you can play that for us, let's see what's going on there as we speak to some people pale kwa ground. Before, as we get it, the fact that Helen already did a feature on exactly how much money is owed, who it's owed to, how much of it is unaudited, how much of it is from insurance claims and all of this. But we'll get to speak to, of course, the chairperson of SHA and actually get those numbers and see if he does agree with them. But 30 billion is a lot of money. And what does it mean for the average person who's now going to a facility, either in Nairobi or in a rural area or in another city, and they're not able to get health care because 30 billion is a lot of money. And sometimes even 1 million for a small hospital is a lot of money. 100,000 shillings is a lot of money. Yeah.
There's 650 facilities who are members of RUPHA. RUPHA is the Rural and Urban Private Hospitals Association. And all of them have a notice at their door today, which says, if you come to our facility today, we will not be able to give you the services under RUPHA. And that is a big one, because when a notice reads like that, says this hospital deeply regrets to announce the suspension of medical services under SHA and AON insurance schemes from Monday 24th. With this notice, we wish to inform all our staff, patients, and the public at large that from Monday henceforth, patients seeking health services under SHA will have to make cash payments. This is because despite giving quality and prompt medical services to both SHA and AON, both insurances have refused to settle the massive arrears and debts owed to our hospital. This directive will be in force until further notice. We apologize for any inconvenience caused due to this unavoidable decision. Now imagine going to over 600 facilities and this is what you get. And that's why we invited the chairman of SHA here, Dr. Abdi Mohamed, to come so we can have this conversation. Dr. good morning.
Good morning.
How are you?
Thank you.
Right.
Well, thank you for inviting me. And I'm happy to clarify most of these issues.
All right.
Yes.
You call it, it's a clarification, which means that there's a misunderstanding somewhere.
There is misinformation.
Misinformation?
Yes.
That's what you call it?
Yeah, part of it is because of, you see, you have talked about AON and SHA.
Yeah.
See, those are totally two different entities.
Yep.
They are not connected in any way.
Yeah.
Yes.
But there's SHA.
There's SHA.
All the 650 RUPHA members who are not accepting SHA services today, it is SHA.
I will explain what SHA has done, how far we are, so that we know who is supposed to have done what at what point.
Before we get into that conversation, we like to look at, famous words that have been said, quotable quotes. Some of them may not have been famous when they were said, but because of the relevance that they have, they actually now then become famous. And our good girl Jano will give us that. Let's just listen to she'll give us a couple of hints of who said it, give us the words, and then ask us who said that.
Right. As we seek to get a lot of clarification, because this conversation is so critical, the person who said this quote, I've described them in the past 2 hours as an icon of music. He's from Nigeria. His music continues to be played, and his son also was able to step into his shoes. It's not easy to step into the shoes of a father who is this iconic musician, but he did. So now we're thinking about the father. So think Nigeria, think one of the most famous musicians to come out of Nigeria ever. And he said, music is the weapon of the future. Who said that?
Nigeria.
80s.
80s.
Father-son.
Father-son was probably, it has to be Kuti. Fela Kuti.
There you go, yes, it is. It was Fela Kuti who said that.
The musical doctor.
Very much so. Or activism in music. Right.
Yes.
What do those words mean to you? Music is the weapon of the future.
I think you can use music to communicate a message, and hopefully we'll have the issue of universal health coverage, maybe in a song, because maybe that's what people relate with easier than written words. And I've seen this through SHA, because everything that I keep on repeating is in writing. They're in documents. But you keep on hearing, we don't know, we don't understand. So it seems we are generally oral, and what's expressed is what people retain and keep in mind. And I'm sure there has been a few famous other words which were said. There comes a time. You see those things where you remember, if it was written somewhere,
you would not have remembered.
Most probably you wouldn't have recalled.
Some famous advertising jingles still ring to date.
Yes.
You hear and you remember the jingle, because it connects and it resonates. Maybe you should actually consider that.
Yes, exactly.
Making a SHA jingle or SHA song to explain the process of how you can get services through SHA. Yes. But let's begin with the 600 plus health facilities across the country who are members of the Rural and Urban Private Hospitals Association of Kenya, who this morning are not accepting, have suspended services under the Social Health Authority due to unresolved payment issues.
So there are a few things that we need just to clarify so that we are on the same page. In 2018, there was a task force that was formed called Panel of Experts. They looked at and came up with a document called the NHIF We Want. And one of the things that they did was to look at what are the weaknesses, what are the challenges NHIF faces at that particular time, and how do we fix those issues. So one of the profound things that they have put in place was sustainability was an issue for NHIF. And they said some of the schemes will collapse in 2020. The expenses will supersede the revenue. In the others, they said it's 2022, and that was one of the recommendations, was just to change the architect of NHIF. That report is what we tried to replicate in terms of how do we come up with an institution that's financially sustainable and is able to pay its service providers. SHA was born in the process. The biggest expectation, which everyone rightly believes so, is SHA has inherited both the liability and the assets, which is correct, and I'm not in denial. But what we need to look at is how has SHA been since it started to date? Was it able, or has it been able to meet its the obligations? And I can tell you today categorically that under the claims that we have received for NHIF, under SHA, that's the fund, 17.5 billion, and we have paid it all for October to January. Meaning, despite our contract with the provider saying that we will settle claims within 90 days, the 90-day period, we have been able to do on a monthly basis. Because we understand that there has been pending bills for NHIF, that facilities still need cash flow to continue providing as we settle on what are those pending bills. So the first time what we got was a total of 30 billion. This figure that is being mentioned left, right, center, so that we are clear. Out of that 30 billion, 9 point something, close to 10 billion, is for WIBA, work injury benefit, which NHIF was doing. And in essence, that shouldn't have been their core mandate. That should have gone somewhere else because they are not equipped to handle. And it was a co-insurance with a private insurance. So that money is around 10 billion. Out of the remaining 30, we have settled almost 9 billion since around July to October, mid-October last year. So what we have was around 10 billion. But something usually happens, you know, when we have those things, facilities are used to submitting claims. So what is happening currently is a process of reconciliation with the individual providers. Because, you know, you don't want this general people saying, oh, there is this much. Rather than doing that, we have gone to each facility, and that process is 60% complete, to have a reconciliation process to see what claims have been submitted, what has been paid under NHIF, or what has not been paid, what is disputed, and what is payable from this other end that says this is clean, there are no issues, there's no problem, this is payable. This one, there are issues in terms of either the documentation or the person was never treated or the whatever is in the claim and what is in the notes are not agreeable, or you provided service out of the benefit package. So that's an ongoing process.
So, Chairman, what you're saying,
yes,
is that the reason why these facilities have gone on strike being unresolved payment issues, that is correct. There are unresolved payment issues.
There are payments that are pending, which was under NHIF.
Okay. So there are unresolved payment issues.
There are payments that are pending. But under SHA, since October, there are no pending claims.
As far as the health facilities are concerned,
yes,
they are owed money.
Yes.
So that's a correct position.
Yes.
They are owed money.
Yes. That's correct.
Okay.
That's correct.
And some of these, what you're saying, are historical bills.
And some of them go as far as 2016.
Okay.
2016, 2017, 2018, 2019, 2020, 2021, 2022, 2023, 2024.
Many years.
Yes.
Under the same government of the Republic of Kenya.
Yes.
Okay. So, as we were rolling out universal health coverage,
yes,
last year in October, November.
Yes.
SHA comes into operation.
Yes.
What was the plan?
So the plan...
And was this plan communicated to these health facilities?
Yes. So the plan was that the pending claims, actually there was even a transition committee that was doing this, doing both assets and liabilities. So the plan is the pending bills, and that's why there was continuous payment, even in 2023 and 2024, until October. There has been payment that has been ongoing. So from 2024 October, when SHA started, is now when we haven't made payments, but we have made payments under the NHIF contribution and the primary healthcare fund, which was for the first quarter and for now up to end of January.
So you're not answering. The current, the 17.5 billion shillings between October and January, okay. But you still
you know that's the largest amount that was paid ever. Yes.
But you still owe the facilities
yes.
a lot of money for very many years.
Yes.
What was the plan?
The plan is to do verification and then make a payment plan.
And that's what's going on now. You say 60%?
60% complete.
60%
complete of the verification.
And in the meantime, it means that services are compromised, suspended. So it's like something, there's a glitch that's not working in parallel.
Yes.
Because seeing these headlines quite often, and even this latest one on RUPHA, still means service, patient service access is now going to be compromised even more. So even as you're trying to complete the 60%, so when do you even anticipate getting to 100%?
I think that should be done within a month at most, because you see, this one has to be a reconciliation with each facility. You're not doing it with an association. So you are doing both facility by facility. And that is around 9,000 facilities. So you have to, and across the country, not just in one place. So it's being done in each facility at that level, looking at what is the claims, what's pending, and what is payable and what's not payable.
And what about patient access in all this time? What happens then?
The patients are still accessing services.
Not as of this morning.
We have 9,000 facilities contracted. 9,000. As I speak, if not close to 10,000. Even among the 650 that you talked about, almost all or half are still giving services.
That's as of this morning?
Yes. Of
the 650 that have said
if we look at, once we look at our claim, we are able to see who has logged in and who is claiming. So that is an ongoing process. And it's very clear for us in terms of that we need to address those issues, historical. But at the same time, we have to verify. You see, this
verification story by government, by the way, is something that you've got to explain. You contracted a facility, and there was a way in which the facility was to invoice NHIF or whatever. The facility invoiced NHIF. And we all know that before anything happened, even in the NHIF era, there was something called pre-authorization. That means that there's an officer at NHIF who pre-authorizes and says, yes, you may go ahead and offer this service, and this is the maximum that we are going to pay for this particular patient for this service that you're offering. Are we saying that those, we are now reconciling to see whether the pre-authorization was offered by a human being?
Now let me do the bit of clarification that I talked about even earlier.
Yes.
So the system that was there was not intelligent enough to say this is the amount which is fixed.
Explain.
So, for example, the amount that is supposed to be paid for a procedure is 10,000 shillings. You are able to claim 20,000.
So when you pre-authorize the procedure, it's written there that it's going to be 10,000 shillings.
So number one,
that's your maximum.
So number one, facilities had contract. They were not standardized, the contracts. So what was paid in a public hospital, 10,000, in private hospital was, for example, 30,000. Even within the private hospital, what was paid at level 4, 30,000, at level 5 was 50,000. So have you seen confusion number 1, where you have same procedure?
I see discrepancies.
Yes, same procedure being done with different. That's number 1.
Okay.
Number 2, within NHIF, you had different schemes, close to 96 schemes.
96.
96 schemes.
And what's your scheme?
So
Scheme
what?
sounds
So
negative.
Scheme, the word scheme,
Scheme.
has a very negative connotation.
So you had what was called managed schemes. So you have the national scheme, which was for everyone. Then you had a parastatal will come and say, we have X number of staff, we want you to cover as NHIF. Pay a premium and demand certain benefits for their staff. So they will say, for us, maternity is 100,000. That's what you pay for cesarean section. Janet will come from County X. She says, I'm the county governor. I have my staff. This is what I'm paying as a premium. And for me, maternity is 200,000. So 96 of that.
Okay.
That you have.
I think different programs.
Different programs.
Okay.
Each with a different benefit and different prices. So this same facility is seeing all. So you are claiming for this, for this, for this, for this, and the system is not digitized or intelligent enough to tie each claim to when you are submitting, that it denies you and it tells you the amount for this one is 50,000, you can't do. Have you seen the mess?
I can see that.
So that is where now,
so
why you have...
When you went to facilities,
yes,
and you were seeking services,
yes,
they would first tell you, we have submitted this to NHIF.
Yes.
For us to get pre-authorization.
So I was coming to the second part.
Pay.
Now I was coming.
When Janet from County X goes,
yes,
and she needs this service,
yes,
she will be asked, wewe uko kwa scheme gani?
Yes.
She'll say, mimi niko kwa scheme ya Kajiado.
Yes.
And then the pre-authorizing officer at NHIF ought to have known, scheme ya Kajiado, maximum 20,000. And pre-authorize 20,000.
And underline the word ought. So that you understand where the chickiness comes in.
Okay.
And the unsustainability. So I ought to have said for Eric is 20,000.
Yeah.
But because this thing is not a document, like the way we have a benefit and tariff and a SHA, which is gazetted. So I say, Eric, umetuma ngapi? 20, ongeza, make it 50. So I make it 50. And then you proceed and approve 50. Now when the claim processing starts, now they will say, no, this can't be 50.
But that's a very dangerous glitch to have at that level.
Right.
Thank you very much.
Even from an auditing perspective,
yes.
How do I audit now? How do I find Janet to come and see that, Janet, you were from Kajiado, your maximum was 20, but you got 50
and
somehow?
in all those facilities.
Now you understand why we had to go where we had gone and create SHA. It's to address all those ills. Currently, we pay providers equally, irrespective of the ownership of the facility, whether it's public, whether it's private, whether it's mission. 2, we don't have people who are more equal than others. The benefit is equal. And contribution is equal, 2.75%. That creates equity. That is the hallmark of a social health insurance. That's the whole essence, that you have equal benefits, you have equity in contribution, and you have access.
Without access, it's on paper fantastic, but without access, I feel like that's the hallmark of a good, healthcare system, that you can access that healthcare easily without feeling the financial pinch, right? But now if I have to go to a facility and I can't get, my SHA is not approved, or I go into a facility because it's private and they haven't gotten their 30 billion from the previous scheme, quote unquote, now I can't access it. So of what good is SHA if patients can't access it?
And that's why we have claims worth 17 billion. It means there are people who are accessing services and being given services as we speak. And that's why we have made this payment to the providers. If you ask providers, they will tell you that they have received money, that they were expecting 90 days, but they have received much earlier. So that is the whole issue. So expect a lot of more noise in terms of certain providers. Anyone who was doing genuine business, providing services, will not have any issue with the current system. Because what's going to happen is patients will get services based on their benefits and tariffs, which is well known. And you will not find this issue of people fighting to say, I am level 4, I am level 5, because that also equalizes. Counties will not have an issue of saying that they are being sidelined. So what they need is just to do now, provide services, so that the patient is at the center of this whole scheme, that they are the ones. And one of the things that which we are finalizing is the patient is able to see on the app, which is not yet up, is claims have come from Eric's facility saying that I have undergone this procedure and they have claimed 20,000. So if you have an issue, you'll be able also to walk and say, this is not true. So that is the issue of also transparency. The second thing is, on your side, you are able to see if your employer has deducted but never made a contribution. Because at the moment, sometimes we also face this backlash. Someone goes to a hospital, they are told they are not eligible, but they say, I've been deducted 10,000, 5,000, 2,000, but without realizing that it's their employer who never submitted their money. And one of the biggest culprits is
the government.
It's government, yeah.
Of course.
Let's take a break, Dr. We have very many questions that are coming in, and we have to ask you all of these questions, sequentially as we move. Dr. Abdi Mohamed, the chairman of the Social Health Authority, is our guest this morning. We're asking ourselves, so what are all these issues with the Social Health Authority, with SHA? Are people able to access services on SHA on time? Are all these facilities by the Rural and Urban Private Hospitals Association, 650 of them, that are saying from this morning, unless you have cash, we are not sorting you out? What happens there? The clinical officers are on strike, and one of the things that they're saying is that because they're not being onboarded onto the system of SHA, so they can offer services at level 1, level 2, level 3, 4, 5, 6 facilities. What are the issues here? We'll address all of them after this break.
Because a lot of people don't feel like there's adequate communication. If we can even throw in somebody here, Matthews Ndubi, who said, despite discussing access, the system is worse than NHIF. How does SHA plan to improve access? Organizations are withdrawing. Shouldn't they engage in dialogue to find solutions? One such comment on YouTube.
So in terms of dialogue, yes, and I think that the ministry is leading, and we have been engaging with providers regularly through their different associations, and that is the religious ones, RUPHA, CAF, and KHF. It's not something that is new to NHIF or SHA. And more importantly, a year or two, I was the chairman of Kenya Association of Private Hospitals. So I was on this other side, engaging with NHIF. So I understand the issue of dialogue. And that's why, in terms of payment under SHA, those are the things that we have tried to fix because it used to be a pain. And that's why you see these claims are as far back as 2016. So we don't want to start that culture again under SHA. Despite the 90 days, the push to the management is to settle. As long as you have the money in the account, there's no justification why you shouldn't pay. And the other thing that has happened is for SHA, the administrative cost is capped at 5%. Mm-hmm. So the 95% is not yours. Mm-hmm. So whether you keep it in the account or not, there's no day you will be able to use it. It's for the provider. So the question that we also, those are now cultural and organizational change that you have to inculcate, that this is not your money. Please pay the provider promptly. Don't keep for them. Let them keep their money so that it gives them an opportunity to improve on their service delivery. We are more than aware on that part.
You're running on this. So you can clearly confirm here that SHA is abiding by the law and not spending over 5% of the 6 billion shillings plus that you receive per month from SHIF alone on administrative.
Yes. Because if you don't, I will find myself in EACC.
Okay. Yes. Another question was raised here by Peterson. Peterson Washira is the chairman of the Kenya Union of Clinical Officers. And he mentioned something, though in passing.
Yes.
And he talked about you as a chairman.
Yes.
And you've just brought it up here. Chairman of Social Health Authority. And you are a player in the private sector. And you've just mentioned here that you are the chairman for 2 years of the Private Hospitals Association of Kenya. You are associated with a health facility. Is there a conflict of interest?
No. I was associated as the chair of Kenya Association of Private Hospitals. I was associated with a facility which I had started in 2011, and I sold to a private equity fund. So I have no shares and no equity in any health organization, in any hospital currently. And I knew, because, this thing will come up. And I exited in 2023. I was appointed last year, September. So I left 2023, June. For my own personal reason. But would I be a provider in the future? Of course, yes.
Once you exit?
Of course. Okay. Once I exit, because I can see SHA has fixed many of the problems. And now being a provider on this other end,
you can reinvest.
Will be, because once you do these things, I will give you, for example, one of the things that people might not say is, you needed to wait for 2.5 years to be onboarded by NHIF. And that will take us to the next question, which was there were many regulators. NHIF staff were also doing individually the onboarding. When you go back now to that report of the NHIF we want, it recommended that those two things to be separated. Why? So that you don't have conflict. I'm the payer, so I shouldn't be the one again to come and say, let's impanel this facility, let's impanel this one, let's impanel. And then you make the process tedious, and that's now where you create checkpoints for individuals. Now all you need is you have been licensed. As long as you are licensed, then you are onboarded, and the contracting is online. It's e-contracting. As a facility, you don't need to know anyone at SHA to be contracted. Your services are listed in your entity that licenses your regulator. And that's why you will realize that being onboarded has been devolved away from SHA. Someone else does. And contracting is done online. To live within our means, we have done it online, and we have used the internal advocates. Previously, that exercise costed 1 billion shilling.
It sounds like it's working on paper.
No.
Not on ground.
on contracting.
No. I'm talking about the system of SHA. I think you've spoken specifically to contracting.
Yes.
2 very quick examples, because it's good to give lived experience.
Yes.
And maybe we've given them before,
yes,
which can be frustrating because it takes us round
yes,
in circles. In fact, somebody on YouTube is just like, hey, can you just tell us if SHA is working or not? It sounds like it's working in principle, but not when people go out. Somebody here says, I'm listening. Last week I was hospitalized, had to pay 17,500. As SHA indicated, my company hadn't paid, but I do have indications that it paid. It's a hoax. I'm not the only one in our company who's gone through this. Who's going to refund me? Of course, you know it's Kenya, so it's gone. That's Teddy. And then somebody else here has reminded us of Grace Njoki Mule, the lioness of SHA, who was arrested by a hospital that's linked to you. I know you've already spoken about that. I think bottom line, this conversation is critical, probably wouldn't be able to complete all this in one session, but because it's such a pain point for every Kenyan listening, you're explaining, fine, you're even talking about dialogue, you're talking about the fact that you've had to migrate, but it just doesn't seem to be working. It's a loaded question. What is that one thing? Somebody here, this person who's saying, I'm not going to get this 17,500 shillings back. It's gone. And I know this is Kenya. I will not get it back. I'm stressed, I'm tired, and I'm still in pain, and I'm still sick. Okay, what do you say to Teddy?
So I would like to say sorry for the experience for Teddy. And this is what I was talking about on the issue of deduction vis-a-vis the money not being received on this other end, or not showing up on this other end as someone who is paid up. And that is now what we are addressing, so that individuals can receive, if you have been declared as an employee, that you actually receive a message saying that we have not received your contribution, so that now you can take it up with your employer to figure out where was the gap in terms of how come that money has left my payslip, but it's not showing up on the other end.
All right. Sorry. So, for example, someone sent a message saying, please ask the SHA head about this baby that died. SHA refused to settle her overseas claims worth 500,000 since last year. There are hundreds of sick Kenyans stranded abroad in hospitals with the same predicament. What is the government doing to sort them out?
I think anyone who had gone and had guarantee of payment, because that's what NHIF used to do. Under SHA, nothing, no one has gone overseas for treatment so far. But the people who have gone when it was NHIF, the facilities have contracts with SHA, which SHA has inherited. And guarantee of payment meant that you can be given services. And that's how it was working. No one was being given money directly to them. It was going to the facility.
Right.
And that's something that the management, the CEO and his team have been able to sort out, especially facilities that they have had an issue with to address. So when you have a specific case, I think they are able to handle directly with the facility.
Because the management here being
the CEO.
The CEO
of
SHA. Okay.
And the whole team.
So they're dealing with, so that no, because there's Kenyans who are saying they are, either stranded in hospitals overseas and able to pay, and those bills do keep piling on. Is there a sense of urgency?
Yes. There's a whole team that handles overseas under the previous NHIF that are still working and handling the same cases. So when you have individual cases bringing their attention to a facility in India that has an issue, they're able to address it.
I want to open the lines, but I know Eric has a question before we open the lines for a caller.
Yeah, we can take 1 or 2 calls. And Daktari, from your leadership of the Private Hospitals Association,
yes,
then you have access to the network. Are there health facilities that have closed down? Private health facilities that have closed down, and the reason that's been given, one of the reasons given, is because they are unable to continue operating because of debts owed.
They might be, definitely. There might be facilities, and that's why I was told you this has been a pain, the NHIF debt. And I told you it goes as far back as 2016. That clearly tells you that there was a fundamental problem in terms of the architect of that financing mechanism. Yes, definitely.
They closed after NHIF. When NHIF was operating, despite all these challenges that you're referring to, those facilities were operating. After NHIF was disbanded and SHA came into effect, those facilities collapsed.
I don't know whether you can do that causal. Is it one came after the other or they are directly correlated? I don't know. But what I know is there are many more facilities that have been onboarded after SHA came into effect. A process which was taking 2 years was reduced to 2 days or 3 days. There were many who were locked out. So the many who were locked out, the hundreds, in the thousands, have now entered into the space of providing services to SHA. So would I also be able to say, because now there is a lot more competition in that space, now anyone who was in that space alone now is unable to sustain because there are a lot more newer facilities with better equipment and more...
the jury is still out.
Exactly. So that's why I don't want to correlate the two.
All right.
Yes.
Oh, sorry, go ahead. No, I was just going to ask whether there's a caller.
Yes, yes.
Or is there? I can't hear.
Jackson, is our caller ready? So we can hear from them. All
Not
right,
yet.
perhaps not. That's all right.
Yeah, I wanted to ask, earlier on you talked about settling an amount by end of March. Did you say that?
No. What we settle on a monthly basis now is the debt that's owed to SHA, which so far is almost 17 billion unsettled. So on a monthly basis, what we are doing is to make sure you get, despite the contract saying 90 days, that you get paid after 30 days, or sometimes even within 30 days, because the generic claims have been paid. And we are February 20th, today is 22nd, 24th, yes. So some of it is less than 30 days because the claims that reach 31st have already been settled. They are less than 30 days. So that, for us, that's the idea, that every facility receives its claims promptly, in as quickly as possible.
Okay. Yeah, just from Global Peace Ambassadors, explain to the public how the money owed will be settled so that patients can receive services.
We have, once we have this reconciliation and we have those sign-offs meaning that you are the owner of the facility, we are in agreement that this amount is clean, no issues, you sign off. This amount has a dispute, you sign off. Then once that comes to the board, then we are able to take it to the government and find allocations based on that and have a timeline on payment. Some of it will come during the supplementary budget and some of it will come during the June, July
the next budget.
Yes.
So the 60% that you said have so far been verified.
Yes.
You have not started paying.
No. We haven't. You see, that's
you've already verified. You've seen we're in agreement that we owe you up to 60%
of the facilities. Of the facilities, not claims. Not yet. But that's what is ongoing. So that once we have the global picture clearly stipulated that this is the amount and this is what is pending, that's what we are now able to settle.
The 60%, how much does it amount to?
So far, we haven't reached the higher. That has been level 2, 3, 4. The bulk of the money comes from 4, 5, 6.
So what's the 60% amounting to?
So actually it could be even 1 billion or 2 billion or 3 billion. Because the bulk of the work
I'm asking
comes,
that because
yes,
if you've already done the 60%, the supplementary budget is now currently before Parliament.
Yes.
So it's either it's in this supplementary budget or it's not. What are you telling facilities? Have you applied for this current supplementary budget to cater for these pending bills?
Yes.
What amount?
There are money that we are expecting from the same supplementary budget.
How much?
We have 6, and then from the ministries, that is Ministry of Health and Ministry of Public Service, another almost 3.
So 3.6 from...
No.
3 billion,
We have
3
for the emergency chronic and primary health care.
Okay.
And then there is the Ministry of Public Service. We expect another 3.2 from their end. And then, so that also covers for civil servant scheme. And the Ministry of Health, maybe another 1 or 2 billion. So the idea is that
catering for all debt?
Yes. Some of it is for all debt. The ones for primary and emergency is current.
That's the current.
Yes. The ones that come from public service will be a mix, because civil servants had their cover previously plus ongoing as well. So you will have a mixture for civil servants.
So you don't know exactly how much of the old debt you are likely to get in the current supplementary budget?
I don't have the exact figure. Okay. I don't have the exact figure.
As we conclude, there's a question that was asked of you by members of parliament during your meeting in Mombasa. It was highly publicized. And one of the things that came out was even MPs, despite them passing the laws and oversighting, they don't have confidence in SHA. And they asked you directly, why don't we revert to NHIF? Because the SHA rollout is not working. Many of the people who are also sending comments here are saying, why don't we just go back to SHA? Tell the nation today. Can we go back to SHA?
Can we go back to NHIF?
To NHIF, sorry.
Yes.
So we go back to 2016 debt pending. That's what you are saying.
Yes.
We move away from
people are feeling that the rollout of the Social Health Authority and the management of Social Health Authority of universal health coverage is not working. Let's just go back to the previous system as you guys sort out your house.
That's what I was explaining. Going back means 2 things. One, we go to the financial unsustainability and pending bills from 2016, vis-a-vis settling of claims monthly. So I don't know which one is working. The one where you are settling your claims promptly on a monthly basis, or the one you have to go back to 2016 to settle claims that are still pending up to date. Let me continue so that
the one I go to a facility
and I get treated. That's the one that's working.
And there are many millions of patients who are getting services as we speak. And the number of people who have registered is 20 million as we speak, from the 9 million that the NHIF had. So meaning there's a disconnect. And it seems the disconnect is somewhere where there are actual patients who are getting services, being treated, registering, getting services. And then there is the general, what is the word? The in thing of to say we don't understand, or
let's hear from someone.
So for some people, they would you see, all these issues are issues that were there previously, even under NHIF.
I don't want to lose a caller. There's a caller on the line. We don't want them to drop.
Okay.
We've got Nyamburi from Mariakani. Mwamburi from Mariakani. Good morning.
Good morning to you. How are you?
Very well, very well. What do you want to ask the chairperson of SHA, Dr. Abdi?
Yes, you go to the hospital, you are subscribed your medicine. When you go to the pharmacy, they don't have medicine. You go outside and buy it outside. Is it normal?
Okay. Is it normal? Thank you. We've also got 1-0. Maybe we take them back to back. 1-0, good morning.
Good morning.
Please tell us what your question is for Dr. Abdi.
Thank you. My question to Dr. Abdi, who has been very interesting to listen to, is what's the point of a health insurance that will not pay a cataract surgery for an 80-year-old? Why would anybody that's been paying for NHIF, and some of us would pay for more than 3 years, like my parent in this case, and then NHIF declines to pay for a cataract surgery, will SHA chief now pay?
That's a great question.
Wanjiru, is there a specific case, like, are you saying that you have taken your parent to a hospital and SHA declined to pay for this operation?
NHIF, yes, NHIF declined.
All right.
And because her payment covered both the period of NHIF and this transition one, meaning her NHIF payment was valid until end of February. My question is, why would a social insurance policy not pay for an 80-year-old that needs a cataract surgery? What's the point?
When were you in hospital? Just so that he can respond to this.
Last year.
Last year.
And then,
month?
Yes. Last year, April.
And then have you been back
and
since?
And NHIF declined to pay.
Have you been back since October?
Yes.
Which month?
January.
So last month.
And we are waiting approval for SHA.
Okay.
We're still waiting for approval from SHA.
All right. Doctor, you can respond to that one.
So on this issue of waiting for approval, I think unless I get the specific, it shouldn't take more than 24 hours.
So what should she do?
She should be able to reach out to the SHA, any branch, which is close, or Huduma Center, and they should be able to handle that issue.
She's still on the line, she can hear you.
Yeah. So that we are able, and alternatively is to get the number and then connect someone to find out exactly, because sometimes you have an issue, either the registration in terms of up-to-date, in terms of eligibility. So those are the things that we need to clarify. But if the facility have requested and pre-authorized, it shouldn't take more than 24 hours. Will be a very unique case. From January to now, it will be very interesting to find out where exactly is the gap.
Okay.
We don't have a backlog of even 72 hours for pre-authorization.
Wanjiru, we'll take your number and give it to Daktari, then he can call you right after this, so that you can deal with this one.
Personally.
This particular case. But what you're saying is anybody going to a facility today, and the application is made, within 24 hours, that approval should come.
And actually, it comes even to your phone as an SMS.
The issue of pharmacists.
So the other one is, I think, it's something to do with breach of contract. And this is where now some of the problems that we are facing with facilities is on the issue of capitation. So what happens is you are paid for this person's services, but when they come to you, what you do is you just do consultation and then you don't give medicine. You tell them to go and buy outside. That's breach of contract, because the contract is in such a way that you are supposed to do consultation, do lab tests if necessary, and provide medicine. You cannot substitute or decide to do one and leave the other. Those kind of facilities is what the public need to report to the nearest SHA facility offices and say, facility X, I went, I wasn't given medicine, I was given a prescription, and we'll take the necessary action for that facility because that's breach of contract.
Dr. Abdi, you realize there are very many questions.
I was going to say.
We will invite you now for, a micro ground.
Yes.
Abdi here, let the people engage you
idea.
and call you. So then you can respond. You can come and your CEO can also be on the line. So there are some issues that are administrative.
So there are specific things that we should be able to handle. And I would like us to look at this thing in terms of as a road to universal health coverage. We have addressed, if you read that report of the NHIF we have addressed most of the ills that were in NHIF. And the reason why we have done it is in such a way that the administrative cost is capped. The rest of the money remains for benefits. The benefits and tariffs are published. And we are able now to increase those benefits and tariffs as long as we collect more money. And that has also been taken away from SHA, and it has been given to a panel of experts, which you as an individual or an organization can actually petition and say, we want you to add the amount of money which you pay for ICU. We want you to add the amount for cesarean section. We want you, and then they look at and say, yes, there is money that's available and we are able to give. But more importantly, the social health insurance works when it's mandatory, and I hope the courts will make that ruling because that is one of the issues that is being canvassed. That gives us all the necessary resources to expand the benefits, to expand the tariffs that we pay to the providers. And we are able now to have a more comprehensive
Let me tell you something,
insurance.
Mandatory or not,
yes,
if this thing works, people will voluntarily contribute.
It is contrary to all scientific
logical
research that has been done anywhere. Because what happens is people who do voluntary only do on adverse selection. So what they do is they register and pay when they are sick.
When they need.
When they need to use. So meaning someone will pay 1,000 or 2,000 because they have realized the procedure they need is 300,000. And that's what made NHIF also not sustainable. Because people who only pay voluntarily are likely to just take when they are sick. At the point of use.
Okay.
And at the point of use, it's difficult.
We have got to let you go.
Yes.
Thank you very much.
Yes. Yeah. We've kind of got into it's very valid conversation. I really like Eric's suggestion about taking this to the ground because it is a pain point. Sharp pains. That's our what we've branded the conversation. But we do have another conversation coming up shortly. Bina Maseno, governance analyst, youth and setting the political agenda. We were just speaking with Dr. Mohamed Abdi, Chairperson, Social Health Authority, making SHA make sense. I hope we have to some extent for you all. If not, let's just keep the conversation going on our social media and on our platforms. But we will be right back with Bina Maseno.